welcome to Voices of Wisdom, Thyroid's podcast designed to share thyroid cancer pearls of wisdom from clinicians for clinicians. You can think of it as kind of a fireside chat where we talk to international experts who share their wisdom and offer practical advice to clinicians in a variety of common and sometimes complex clinical scenarios. I'm your host, Dr. Dana Hartl. I'm a head and neck surgeon at the Gustave Roussy Cancer Center in France, and I am very excited to be your host of Thyroid's Voices of Wisdom podcast. I will be hosting this second season of Voices of Wisdom, stepping into the shoes of Dr. Janice Pasieka, who pioneered these podcasts. I want to take this opportunity to thank Janice for all of her hard work on making these podcasts a reality, and congratulate Janice and all of those who contributed to the success that they have become. In each podcast, we will be meeting with one or several international thyroid experts, and each episode will dive into a specific topic related to thyroid cancer care. Our aim is to help clinicians deal with issues that are often complex, and our aim is to provide as much evidence-based information as possible, but also practice-based information and tips from world-renowned experts. In each episode, I'm joined by a distinguished international guest who brings their unique perspective and expertise to the discussion. So whether you're a surgeon, an endocrinologist, a pathologist, a medical oncologist, or a nuclear medicine specialist, this podcast promises to be a pivotal resource in your quest for knowledge in the care of thyroid cancer patients. Welcome back to part 2 of this special episode of Voices of Wisdom. I'm Dr. Dana Hartl, and if you've just joined us, we're continuing our fascinating conversation with Doctors Fabian Pitoia from Argentina and Iwao Sugitani from Japan, as we discuss varied approaches to managing thyroid cancer, exploring how clinical decisions differ globally based on case complexity and regional practices. In this segment, we'll delve further into this subject. If you haven't yet, I highly recommend listening to part 1 of this discussion to fully grasp the insights of the previous cases. So without further ado, let's go back to this great episode. Great. So, Iwao, you would say just follow this patient up. Fabian, you'd think that most patients will want to be reassured on a thyroglobulin level. And I guess that comes to the next question is, for Fabian, if the patient doesn't want to have completion thyroidectomy, and so you don't have necessarily a really good thyroglobulin, really reliable thyroglobulin to go on, how would you recommend this patient to be followed up? And would you, again, a question about TSH levels, would you look at TSH and would you try to give them a treatment so that you have TSH in a certain range?
Well, we are talking about intermediate risk of recurrence, and probably we will try to keep these patients into, if we chose lobectomy and the patient feels comfortable with the lobectomy and we are trying to follow up the patient, probably we will try to replace if the TSH is above 2, and we will like to have a TSH near 0.5 or 1, but not suppress TSH for this kind of intermediate risk of recurrence. And then, of course, if the patient chose total thyroidectomy, we will follow up as normal with thyroglobulin, and no need of ultrasound if we have an excellent response to treatment.
So like you said previously, if it was just a lobectomy, you would just be using ultrasound to base your follow-up on suspicion of a structural occurrence. Is that correct?
Yes, absolutely.
Well, and same question to Iwao then. So most of your patients, you would just counsel to follow them up. How often would you follow them up, and how would you follow them up? And what do you do with their TSH levels?
Mm-hmm. Almost same here with Fabian. They're going to follow up after lobectomy. There are no strict guidelines, but we primarily use annual ultrasound examination. Thyroglobulin levels are often measured alongside thyroid function tests, maybe every 3 or 6 months. And additional imaging, such as chest CT, is performed when a significantly elevated thyroglobulin level or suspicious neck recurrence on ultrasound was seen. As for TSH suppression therapy after lobectomy, it is generally not performed if thyroid function remains normal. If levothyroxine supplementation is needed, TSH levels are maintained at the lower end of the normal range, like from 0.5, less than 1.0.
So you would use thyroglobulin as an alert that if it was rising or if it was high, that maybe this patient would have distant metastases and then do a chest CT to look for structural recurrence in the chest?
Well, probably if we have a patient with the intermediate risk of recurrence, and we are looking at of course, we look at the thyroglobulin levels, and we see a trend in increasing thyroglobulin level with the normal TSH. I'm not meaning we are expecting a hyperplasia of the remnant lobe, and we see an increase in thyroglobulin level. We would feel very prone to go to complete the total thyroidectomy and use radioiodine for this patient, because probably if we are thinking that we can find distant metastatic disease in the lung, this won't be seen with a CT scan or a PET-CT. Probably this is miliariform metastasis, and we need radioiodine for these patients. So if we see this trend in the increase in thyroglobulin, probably what we would do is to go to complete the total thyroidectomy.
So I guess what you're both saying is you do want to look at thyroglobulin every once in a while in these patients after lobectomy, even though we don't really know the cutoffs, just to make sure that it's sort of stable and it's sort of within a quote unquote, I would say, reasonable range and not rising. Is that about right?
Yeah.
Well, that's really interesting. I think it's a really great point to that you guys bring up. Okay, third case. This is getting more complicated. The third case is a 32-year-old male patient who comes to your clinic with a palpable neck node, and he's already had cytology, and it's papillary thyroid carcinoma. And he actually has multiple lymph nodes in the lateral neck. And the primary tumor is a 25 millimeter tumor in the ipsilateral thyroid lobe. So I'm going to ask Iwao Sugitani, for these kind of cases that the patient has just lateral nodes, the central node, which let's imagine that it's actually clear on ultrasound, there's nothing in the central neck, would you systematically perform a central neck dissection unilaterally or bilaterally for this case that just has these lateral lymph nodes?
That's a very difficult question. And basically, according to Japanese guidelines, patients with massive lymph node metastasis, defined as nodes larger than 3 centimeters or with obvious extranodal extension, are classified as high-risk papillary thyroid carcinoma, regardless of age. On the other hand, the number of lymph node metastases is not heavily emphasized. Regarding central neck dissection, it has traditionally been recommended to perform in Japan, even for low-risk patients undergoing lobectomy. This is based on the rationale that it can be done within the same surgical field. Recurrent surgery may carry a higher risk of complications due to adhesion from the previous operation, and unilateral central neck dissection with lobectomy does not result in hypoparathyroidism. However, with the recent guideline revision, it has finally been stated that there is no evidence that prophylactic central neck dissection improves recurrence rates. That said, for N1B cases, many facilities in Japan still perform central neck dissection in the real-world practice.
So you would do, quote unquote, prophylactic, at least do a unilateral central neck.
Mm-hmm. Yeah, if you need therapeutic, systematic lateral lymph node dissection, we usually do central simultaneous.
Okay, and Fabian, do you guys have the same kind of approach in terms of the extent of surgery for this kind of patient in the central neck?
I think that this time I will completely agree with Dr. Iwao regarding the approach. Of course, this is a multidisciplinary decision, and we as endocrinologists can suggest, but finally, the one who take the decision are the surgeons. And finally, probably if we have a lateral metastatic lymph node, probably we will go with the unilateral central neck dissection and the lateral, of course.
Okay, I really like your remark. I mean, okay, I don't want to intervene, but I'm a surgeon, and I'm like, okay, I'll do what the endocrinologists tell me what to do in the tumor board, and you're saying, oh, it's the surgeons that get to decide. I'm gonna go work for you, Fabian. Then I can decide. Okay, so yeah, well, and this patient has extensive lymph nodes, so at least a unilateral central neck. You guys agree? So after surgery, I'm going to ask Iwao again. Would you propose iodine for this patient systematically? And then, as a corollary, would you use thyroid hormone withdrawal or recombinant TSH? Do you give radioactive iodine? Do you use a fixed dose? Do you dosimetry? What do you do in Tokyo in terms of radioactive iodine?
Okay. For high-risk cases, of course, the total thyroidectomy and therapeutic neck resection are generally recommended. However, in the commentary of our guideline, it is noted that even in high-risk groups, the significance of total thyroidectomy does not lie in improving prognosis, but rather in streamlining management, including subsequent RI therapy and thyroglobulin follow-up. For high-risk papillary carcinoma without evident distant metastasis, our new guidelines recommend determining the need for RI adjuvant therapy based on the postoperative trend of the thyroglobulin levels or thyroglobulin antibody levels, dynamic risk determination classification. In cases without distant metastasis, we usually use the recombinant human TSH used for RI therapy. Dosimetry is not typically performed. And for adjuvant therapy, 3.7 to 5.6 gigabecquerel of RI is administered. However, due to outpatient restrictions in Japan, allowing maximum of 1.1 gigabecquerel of RI, it is not uncommon to administer 1.1 gigabecquerel for adjuvant. Postoperative follow-up is usually centered on monitoring thyroglobulin or thyroglobulin antibody levels and mild TSH suppression combined with annual ultrasound examinations, even for high-risk cases. I personally do not perform stimulated thyroglobulin testing.
Oh, so in Japan, lower doses, like that's 30 millicuries of radioactive iodine, can actually be suggested for this patient. Fabian, what would you do for this patient? Would this patient get radioactive iodine with withdrawal or recombinant TSH?
Well, we will probably not give radioiodine immediately to these patients, and we'll wait for the dynamic risk assessment during the first 6 months, 1 year, to see how the trend of the thyroglobulin or the antibody, if the patient has a positive antithyroglobulin antibodies. And then we decide at that point if we administer radioiodine dose. Usually, if we have a TSH level less than, I would say we were used to use the 5 nanograms per ml cutoff before. Now we have moved after the publication of Thyroid, the article showing that most of the studies showing the threshold of 2.5 as the limit to define a higher risk of recurrence. Probably we will move this, but before we have our experience showing clearly that this dynamic risk assessment is very useful to decide or to define if the patient is going to receive radioiodine dose. So if we have a lower level than 2.5 or 3 nanograms per ml, not moving TSH level, normal ultrasound, we probably would not use radioiodine. And if we use a radioiodine for an increase in TG level, we can use recombinant human TSH or thyroid hormone withdrawal. Another difference from the rest of the countries is reimbursement here in Latin America, where we have a very variable reimbursement from 40% to 100% to our patients. So that is something that can also prevent the use of recombinant human TSH. And of course, if we use radioiodine, we use adjuvant dose, no remnant ablation dose, and we use, of course, 100 millicuries for this patient if we feel that this patient is having persistent disease.
So that's a really excellent point, is that there's the cost of recombinant TSH versus the withdrawal that really comes into play for certain patients. That's a really excellent point. Fabian, about the follow-up, even without iodine, how often would you suggest doing ultrasound on a patient who has a lower level of thyroglobulin?
We usually do it for the first 2 years every 6 months. And then if it is a stable TG level, we go every year from that time on.
Iwao, is that about the rhythm that you would suggest in a patient who doesn't get radioactive iodine?
We perform same as at the intermediate case after lobectomy. We usually do annual ultrasound testing and further imaging like chest CT is based on the thyroglobulin level or ultrasound finding.
Not to, maybe a little bit more frequently in the beginning, and then it's getting it a little bit spacing it out as you're getting more reassured about how stable the thyroglobulin is. Well, that's really, really, really interesting. I'm learning so much here. Thank you. Well, we're gonna finish up on a general question. I'm gonna ask Fabian first. Do you have a feeling about why patients are maybe treated differently? And I think we touched on it a little bit during these conversations, why people in different countries might receive different kinds of treatment.
Well, I think that the main reason probably for Latin America, and then we will have to talk about also the access of drug. I mean, when we talk about advanced disease, we haven't talked about the advanced disease, but for example, here we do not have all the availability of approved drugs for advanced thyroid cancer, but it's a big limitation for our patients. And again, not having the access to drugs or a recombinant human TSH, for example, can make a really, really very different approach. And we have to be very creative with our patients when we have to choose treatments. And there is, of course, another point, which is the idiosyncrasy of our populations that probably are completely different with beliefs and everything we have regarding this situation.
Well, same question to you, Iwao. What's your idea on why there are differences in different regions of the world?
In the world, perhaps it's a national character. Jokes aside, I believe that the pioneers and mentors in Japan maybe deeply understood the biological nature of thyroid cancer, putting emphasis on patients' quality of life, and have adopted less is more treatment approach. But actually, the widespread adoption of thyroid-preserving surgery and the reality of radioactive iodine therapy in Japan can also be attributed to several factors beyond scientific evidence, specifically the medical and societal environment. Firstly, Japan is one of the most iodine intake-rich regions in the world, and the relatively low malignancy of most thyroid cancers here may have contributed to a generally favorable perception of thyroid cancer. Additionally, the medical practice framework differs from other countries. Endocrinologists and nuclear medicine physicians who specialize in thyroid cancer are scarce, and surgeons have traditionally managed everything from preoperative diagnosis to post-operative follow-up. It was also surgeons who introduced the use of ultrasound in thyroid cancer management. Consequently, the standard approach of total thyroidectomy, radioactive iodine, and thyroglobulin-based follow-up was not as emphasized in Japan. Moreover, legal regulations around RI use have been strict. As I mentioned earlier, the outpatient administered RI dose is still limited to 1.1 gigabecquerel, 30 mercury. The cost of maintaining radiation shielding facilities required for inpatient treatment is pretty expensive, and there has been a shortage of treatment centers. As a result, access to RI therapy has been very limited. While this situation has been gradually improving, it is still challenging to provide RI therapy for intermediate papillary thyroid carcinoma.
Well, thank you both for those insights and that really fascinating dialogue and different ways of seeing the same case and treating the same case where we saw the similarities and differences. I guess just to wrap up, Dr. Sugitani, do you have a take-home message or something, a message to our listeners from Japan?
this is more of a simple observation rather than the take-home message. But in recent years, there have been notable changes in the management of papular cell carcinoma in the world, including the improvement of iodine deficiency worldwide, the spread of ultrasound users by surgeons, the involvement of oncologists due to the advent of molecular-targeted therapy, and most importantly, the accumulation of evidence through large-scale data. These advancements have led to the global adoption of risk-adapted management, treatment de-escalation, and increasingly similar treatment strategy across the globe. I find this trend deeply impressive and should be evolved in the future for patients.
Great points. Fabian, how about a take-home message or something for our listeners from Argentina?
Well, I completely agree with this idea of putting all these together. Probably when we look at the guidelines and we look at the Japanese guidelines and then we look at the American Thyroid Association guidelines, we like because most of these things can be taken around the globe. But we have to bear in mind for those low-income countries that these situations should also have bear in mind when we discuss these guidelines, because these facts can be completely different for different populations. And probably we need to look at these particular situations that cannot be applied around the globe. And we should be aware that guidelines sometimes we look at it and say, "Whoa, how nice to be able to do genomic interrogation for all patients," but we cannot even do it even for the advanced case. So these are the challenges for the future, trying to perform guidelines with some kind of point saying, well, this is the gold standard, but we understand that this cannot be done everywhere, and so this could be the alternative for these low-income countries.
Oh, thank you. Yeah, for that excellent point, is to say, how can we do as best we can, given the resources, and maybe not over consume medical resources and use our medical resources for those in whom it is really useful. Those are amazing take-home messages. Thank you so much, again, both of you, for bringing your insight from totally different areas and really engaging in this dialogue.
Thank you very much.
Thank you for this opportunity, Dana.
And that officially concludes our extended discussion on 3 clinical thyroid cancer scenarios, where we unpacked global differences in treatment approaches and the decision-making processes behind them. I'm Dr. Dana Hartl, and it has been a pleasure to delve deeper into today's subject with Drs. Fabian Pitoia and Iwao Sugitani. If you have any questions or suggestions for future podcasts, please don't hesitate to email us at voicesofwisdompodcast@gmail.com. We have an exciting season coming up. Please stay tuned for future episodes. And if you liked our podcast, please subscribe to our webinars, which air live every Friday morning at 8 a.m. Eastern Time. Thyro Multidisciplinary Seminars is a series for thyroid clinicians and researchers that covers breakthroughs in thyroid cancer research and treatment in the form of topical journal clubs, state-of-the-art lectures, multidisciplinary tumor boards, and lively panel discussions. So just visit thyro.expert/subscribe or click in the link in the description. Thank you again so much, Fabian and Iwao, for sharing your invaluable expertise and enriching our understanding.